Welcome to 5-Minute Journal Club, Circulating Tumor DNA in the Management of Breast Cancer. This is medical oncologist Dr. Neil Love. I met with Dr. Lajos Pusztai from the Yale Cancer Center in New Haven, Connecticut, to discuss recent key presentations and publications on this important topic. And to begin, Dr. Pusztai commented on a presentation he did at the 2025 ASCO meeting on results from the DARE trial, a multi-center randomized study evaluating the use of the tumor-informed Signatera assay in patients with high-risk localized ER-positive, HER2-negative breast cancer receiving adjuvant endocrine treatment.
DARE is one of the first trials that tries to understand whether early intervention at the time of ctDNA positivity during follow-up of stage 1, 2, or 3 breast cancer makes a difference in terms of pushing away or altogether avoiding a clinical recurrence. So this is a randomized trial where patients, when they turn ctDNA positive, are randomized to continuing their adjuvant endocrine therapy or switch to fulvestrant and palbociclib. The study screened a large number of patients, and we find about 50 up to now that were ctDNA positive after initial negative results, and they were randomized 25 into each arms. So the most important finding from this is that at the time of ctDNA positivity, 75% of these patients don't have metastatic disease. So that's important because they actually have molecular relapse. Those who are persistently negative throughout the serial testing have an excellent outcome. So in this study, with about 2.5 years of median follow-up, nobody recurred. Arm B has a much sort of higher rate of ctDNA clearance, close to 60% ctDNA clearance, that is going from a positive to a negative result. And those who experience the clearance actually have much fewer recurrences than patients who did not. On the other hand, those who fail to clear the ctDNA or have an increase, a rise in the ctDNA sort of quantity, then unfortunately they relapse quickly. So the main message from this trial is that molecular relapse does exist in ER-positive disease. That means that they turn ctDNA positive but remain imaging negative. And patients who clear with an intervention their ctDNA, looks like they have a lower risk of clinical recurrence than those who fail to clear.
So I guess one question about this is very practical. Do you think this is strong enough data that you can justify actually doing this in clinical practice for a community-based doc to look for? I'm guessing a lot of people probably already are doing it, but any thoughts about whether that's appropriate or not?
Evidence accumulates bit by bit over time. So I think the prognostic impact of turning ctDNA positive is unquestioned. So those patients do really badly. So as physicians, we sort of really are obliged and kind of motivated and asked by our patients to do something about poor prognosis, right? So it's reasonable to assume that some form of treatment might actually help, especially when we have highly effective treatments in the metastatic setting or the adjuvant setting. So I think the evidence is bit by bit accumulating. And when it reaches the threshold that the entire community and our guidelines suddenly adopt it, it takes some time. So I don't think that this study alone establishes this as standard of care, but I think it adds to the evidence that that's not an unreasonable thing to do, to switch treatment or add something at a time when ctDNA starts to rise. There will be multiple clinical trials that will address this question prospectively, and I think if physicians have an opportunity to refer or put patients in these studies, that's the best way to really generate evidence quickly so that this no longer remains controversial. We would love to have more patients on that study, but there will be several other studies open nationwide through various cooperative groups and local consortia.
I guess another question would be not just switching therapy, but whether a persistently negative assay, which looks like most people have, might be factored into de-escalation. For example, patients are having symptoms from therapy, or patients hit the 5-year point even. Could you see that potentially in the future being utilized to, modulate how you actually give the hormonal therapy, not necessarily switch it?
Absolutely. So there are several studies, again, in this formative phase, which will open probably within the next few months in the United States. One of is going to be a large cooperative group trial run by Alliance that explores exactly that strategy, that if you are high risk or meet the criteria for ribociclib or abemaciclib in the adjuvant setting, but you are severely ctDNA negative, then patients will be randomized to actually get the indicated or FDA-approved treatment with the CDK4/6 inhibitor or not getting it and starting it only when they actually turn ctDNA positive. And I think Natera is also rolling out a registry trial with the very same sort of idea, but that's going to be not randomized, but a registry where physicians can opt to delay starting a CDK4/6 inhibitor to the time point when the patients turn ctDNA positive during serial monitoring.
So let's talk about this paper from Michaela et al. Looking at the next generation version of the Signatera assay with more probes in patients with localized breast cancer of all types.
This poster really introduces the next generation of the Signatera test. So the Signatera assay that most of us are familiar and which have been used in all the previous studies is a whole exome-based test, where the tumor actually is sequenced, the whole exome of the tumor is sequenced, the core and most sort of dominant molecular abnormalities are identified, and then you build a PCR assay to look for those in the blood. So the original whole exome sequencing-based Signatera used 16 sort of different molecular abnormalities that they picked as the most representative of the patient's tumor, and these were the basis of the blood tests. So the whole genome-based assays are believed to be more sensitive. So they might provide you a longer lead time before the cancer becomes detectable, and therefore a longer time period to intervene. So this is, I think, the first sort of public introduction of the Signatera whole genome or whole genome sequencing-based assay. And the main difference is that, to put it simply, that the original Signatera has 16 probes to look for the cancer. This one has 64. It has the same result as we have seen with the first generation Signatera test, that if you remain ctDNA negative throughout the follow-up period during the serial testing, then those patients have an excellent outcome. If you turn positive, then that's sort of a bad news. What this poster have failed to do, and we're still waiting for this result, is to really compare head-to-head this whole genome-based Signatera versus the whole exome-based Signatera. But I think the expectation is that the whole genome will be more sensitive and pick up a molecular relapse a few months earlier than the whole exome-based older first-generation assay.
So if you just look at the initial post-op cell-free DNA, let's say with Signatera, for example, what's the chance of it being positive in various situations, stage 2, stage 3, for example?
Yeah, so at the time of diagnosis, the positivity rate depends on the stage. And as you would expect, stage 1 is less frequently ctDNA positive at baseline at diagnosis than stage 2, and stage 3 is the most frequently ctDNA positive. But it also depends on the molecular subtype of breast cancer. So the highest rate of ctDNA positivity is with triple negative disease, and then with HER2 positive disease and ER positive disease is the least. However, the positivity rate for a triple negative stage 2 or stage 3 breast cancer is pretty close to 80 to 90% at baseline. And many of these patients will clear their ctDNA during neoadjuvant therapy.
Oh, that's a good point. Yeah, neoadjuvant. Yeah. One other sort of basic question, and maybe I'm the last person to understand this, but we just did a program last night on myeloma, and we were talking about MRD assays in myeloma. I'm just kind of curious, like, what's the difference in how the assay is done, for example, in the hematologic cancers or in myeloma, compared to the way it's done here with something like Signatera?
Yeah, I think our colleagues in hematological diseases have been using and really exploiting this with clinical efficacy, this concept of looking for minimal residual disease And the advantage that they had is that many leukemias and lymphomas have a pretty pathognomical molecular abnormality. That is, that everybody has that particular abnormality, and that's the hallmark of this particular disease. So you could build a PCR assay, 25 years ago when PCR became an established technology to look for the particular sort of hallmark molecular sign of a lymphoma or a myeloma or leukemia. And of course, they also showed that intervening at the time of molecular relapse or for residual disease after original minimal residual disease, molecular residual disease after a curative intent therapy pertains for poor prognosis, and therefore those patients need further therapy. So I think they are ahead of us in that sense. But in terms of the technology, it's really, I think there's no really major conceptual difference. And we caught up with them by this multiplexing the abnormalities, since there is no single pathognomical molecular abnormality that ties together any particular breast cancer or colorectal cancer or other solid tumors.
Yeah, that's really very, very helpful. One other final thing, you used the term molecular relapse, and I'm just kind of curious. I was sort of surprised last summer at ASCO when the SERENA-6 trial was presented, and Dr. DiMichele did the discussion, and she referred to ESR1 mutations. Of course, that was in metastatic disease, but she used the term molecular relapse. And to me, like, ESR1 is not necessarily the same thing as, kind of an MRD type assay. It's more, to me, like a resistance. But do you think, for example, ESR1 mutation development is a molecular relapse?
Yeah, I think we need to sort of come to terms with the new terminology and probably agree on how we use them. But I don't see this particularly sort of difficult or complicated. So in my vocabulary, MRD, or minimal residual disease, refers to the presence of tumor DNA after a curative intent surgery and neoadjuvant therapy is completed. So these patients have no visible cancer anywhere. They completed treatment that we hope cures most, but in their particular instance, it looks like that they were not cured because they have molecular signs of cancer. So that would be MRD, minimal residual disease. And molecular relapse, I think it's like relapse refers to patients who are actually doing well and we think they are cured, but they suddenly recur. So that's when you turn ctDNA positive during follow-up. And I think what the SERENA-6 study actually really tested was a slightly different concept, molecular progression. Right? So these patients progress. They actually acquired a new molecular abnormality that we by and large associate with resistance to traditional aromatase inhibitor therapies or fulvestrant, but they just haven't reached the size of progression to be detectable on imaging. And therefore, I call this, more appropriately, I think, molecular progression.
The next sort of mini discussion I wanted to have with you here, one from data from the PALACE trial, and then an ongoing study, the Signal ER101.
So this was the PALACE trial, and they looked at ctDNA at cycle 1, day 1. So basically when patients enrolled and started treatment on PALACE, and remember PALACE was an adjuvant trial of randomizing patients between standard endocrine therapy or adding palbociclib. So it's important to understand that I think there was about a 6 months sort of grace period. So patients could have received some type of an adjuvant endocrine therapy up to 6 months before entering PALACE. So many of these patients had some prior treatment. But at the time of the entry, which is cycle 1, day 1, they were ctDNA positive, then they did poorly. Their sort of distant recurrence-free survival, that's metastatic recurrence-free survival, was actually pretty abysmal by 5 years. On the other hand, those who had negative results at baseline did better. But of course, they did relapse during time, so because ctDNA could turn positive over time. PALACE used 2 years of palbociclib therapy. But these results are the combined arms. So these results were not broken down by intervention. But again, what this shows that if you clear your ctDNA and you remain ctDNA negative after the 2-year treatment on the trial, then people did a lot better than those who failed to do that. And those, of course, include patients who acquired ctDNA positivity.
How about this ongoing study, the Signal ER101 trial?
Yeah, so that's one of the trials that will open very shortly. It's not open yet. It's a registry trial. And the hope is that physicians who order the test in the context of routine care would also enter patients into this sort of registry. And again, the main question that they try to understand whether you could avoid a CDK4/6 inhibitor in patients who remain ctDNA negative. And if they remain ctDNA negative throughout their follow-up, they just don't get the CDK4/6 inhibitor, even though they meet the FDA criteria or the registration trial entry criteria for adjuvant abemaciclib or ribociclib. But they do start it when they turn ctDNA positive during surveillance. So that's basically like a delayed initiation of CDK4/6 inhibitor therapy in the population that qualifies for CDK4/6 inhibition in the adjuvant setting. It's a prospective registry trial. It's not a randomized trial. I must admit that I'm actually part of the steering committee, so I have the particular conflict of interest with this. But I think that's a practical way to try to get at this question, whether we could spare some patients who qualify for CDK4/6 inhibitor from that potentially toxic and expensive treatment based on their ctDNA negativity.
Is informed consent required, or is this sort of
yes, of course.
People just
so
do
this
it?
It's a genuine trial. So there is informed consent required, and there is central IRB approval.
Interesting. So one other kind of related point to all these trials that I wanted to bring up, because it's kind of a question I've had for a long time, and I see you actually were involved in finding out at least some of the answers. I always wondered, when you look at the deaths from breast cancer, what fraction of those people who end up dying of breast cancer initially had localized disease as opposed to de novo and particularly localized, earlier stage disease. And I see that you've done work on this. Can you talk a little bit, kind of relates to kind of the potential implications of this whole type of a strategy. Can you comment on that?
Thank you for asking this question. So, I trained at MD Anderson, and our philosophy was really not to rest until we cure everybody. So I'm a little bit more sort of in tune with the idea of improving cure rates rather than de-escalating care, because the escalation of care inevitably could harm a small minority of patients by sparing a lot from potential toxicities. So we're actually interested in this question: what fraction of annual breast cancer death? About 40,000 people or women die from breast cancer each year. So what fraction presented with stage 1, stage 2, or stage 3 disease many years before their death? And remarkably, nobody actually did this analysis before. So we looked at the SEER database, and what we actually found, it was a little bit disconcerting, but in many ways very relevant for the ctDNA monitoring field. So over the past sort of 15, 20 years, from 2000 to 2017, which was the end of our sort of database that we looked at, the annual proportion of deaths from stage 2 breast cancer increased from about 26% to 40%. So actually, most breast cancer deaths these days are from patients who present with stage 2 disease.
It's really fascinating to me that you also found that 23% of the deaths were from patients who were originally diagnosed with stage 1 disease.
So why? Because there are so many patients. So it's important to understand that stage 1 breast cancer has a low risk, but a 5% risk of metastatic recurrence means 1 in 20. So if you think about this another way, would you fly an airline which only crashes 1 plane out of 20? So that's not exactly a safe airline. So that's unfortunately the reality, that even stage 1 patients have a 3, 4, 5% risk of recurrence over 20 years. And because there are so many of them, due to the screening and early detection, they account for 220,000 women each year with this diagnosis. So they account for a pretty significant number of breast cancer deaths. So the question then, how do we avoid this? How we improve cure rates in stage 1 breast cancer when 95% of them are already cured? And I think ctDNA monitoring, and if we can prove that intervention at the time of molecular relapse avoids a subsequent clinical recurrence, metastatic recurrence, then I think that's the strategy that could reasonably and possibly improve cure rates in this low risk, early stage 1, stage 2 patients further. Because it's a no-go proposition to intensify their treatment, right? Because it would result in 95% of them being massively overtreated.
So you probably know the question I'm going to ask, which is if you look at patients who do not get adjuvant therapy, and we can maybe break it down into ER positive, triple negative, and HER2 positive. And of course, there are not too many people who don't get neoadjuvant or adjuvant therapy with triple negative or HER2. But if you look at people who are not going to get neoadjuvant or adjuvant therapy with these three subtypes, what's the chance that they're going to be ctDNA post-op?
So post-op is just one time point. So I think the probably more relevant question is how many of them will turn ctDNA positive sometime during their follow-up, either at the first measurement post-op or the subsequent measurements. So it's a difficult question to really answer, but we know that most of these screening studies pick up ctDNA positivity in probably 8 to 10% of the patients that they screen over time. We don't actually have that much data on low-risk patients. So all the currently available public ctDNA results post-surgery in triple-negative disease or HER2-positive disease are in patients who actually are high risk, and therefore they received neoadjuvant therapy. If you take low-risk patients, stage 1, stage 2 patients, and test them post-surgery, there is no data in that space. But I would predict that the hit rate right at the time of completion of surgery would be like 1% or less than 1%. But over time, they will accumulate molecular relapse and ctDNA positivity.
So these next papers relate to neoadjuvant therapy and the use of ctDNA in that situation. Can you kind of briefly summarize what we know from these three studies and in general where things are and where you think things are heading in terms of cell-free DNA in the neoadjuvant situation?
Okay, I must admit that I'm part of the I-SPY team. So we collect ctDNA pretreatment at week 3, which is 3 weeks into a Taxol with or without some experimental therapy. Week 12, which is the end of the taxane component of the neoadjuvant therapy, and patients subsequently receive 4 courses of AC or dose-dense AC. And then they have a T3 time point, which is at the end of the chemotherapy, but before surgery. So this is probably the most important finding from this publication, that in terms of prognosis, what matters is the extent of residual disease and also the ctDNA positivity. There is a subset of patients who actually have a very rapid ctDNA clearance by 3 weeks. So this is just 3 weeks of therapy, and there's original ctDNA positivity, which recall is from the previous discussion about maybe 70, 80, 90% of the patients, depending on the stage and subtype, have baseline ctDNA positivity. So those who clear ctDNA by week 3 have a really good, about a 70% chance to have a PCR subsequently. But of course, they continue with that treatment. But what happens after they finished all the neoadjuvant therapy, undergone surgery, then you have their residual cancer burden, which is the extent of the residual cancer. Those who have a complete response or a very minimal residual disease, they do really well. If you have more extensive residual cancer, but no ctDNA or cleared ctDNA, then you still do reasonably well. On the other hand, if you have residual disease and ctDNA positive, do you really, really badly? So obviously what this means is that those are the patients who will need to push for additional adjuvant therapies, currently capecitabine or TDXD or TDM1, and probably for the triple negative population, ADCs will replace capecitabine shortly. So these plots are kind of complex, but the reason why you have 4 plots there is because the results are broken by for RCB2, which is sort of moderate amount of residual disease, and RCB3, which is extensive amount of residual disease. And they are color-coded to match them by positive or negative ctDNA. One important point to make on this, though, so we really hoped that maybe ctDNA negative patients with residual disease could avoid adjuvant therapy, but it doesn't seem to be the case. So if you scrutinize these Kaplan-Meier curves very closely, then you see that even if you have an RCB2 disease, which is moderate amount of residual cancer, and ctDNA negative, you turn from positive to negative or remain negative throughout, you still have about a 10 to 12% risk of recurrence. And if you have a extensive residual disease and ctDNA negative, you unfortunately, again, you can't avoid, or it's risky to skip additional adjuvant therapy because the risk of metastatic recurrence, distant recurrence, is about 17 to 20%. I think the most important message here is that, unfortunately, patients with extensive or moderate amount of residual disease, even if they are ctDNA negative, their prognosis is better, but it's not so good. That would justify not giving additional therapy. On the other hand, if you are ctDNA negative and you have very minimal residual disease or complete response, then I think those patients do really well.
What about these papers evaluating circulating tumor DNA in the metastatic setting?
So ctDNA, I'm kind of excited about this field because it could really impact practice and help defining better treatments or more sort of cost-effective treatments in multiple disease settings. So we talked about the neoadjuvant space and how the early response predicts for good outcome, and ctDNA clearance, especially with minimal residual disease, leads to good outcome. We talked about the adjuvant space, that how you could use ctDNA dynamics maybe to delay intensified adjuvant therapy with CDK4/6 inhibitors. And we also talked about the surveillance space, right? That you finished all your treatment, and if you turn positive, then maybe intervening at that point could avoid a metastatic recurrence. But the other area where this test could actually have an impact, an important impact, is in the metastatic setting, monitoring response in a more direct and simple and real-time than repeat CT scans. And this is the circulating ctDNA dynamics paper at ASCO that our colleagues showed from Memorial Sloan Kettering. So what they basically did is compared how long patients stay on a particular treatment based on ctDNA clearance or no clearance. And again, I mean, it's kind of a no-brainer, but it's nice to see it confirmed that those who actually have a response, a ctDNA response, which means decreasing ctDNA quantity or a complete disappearance, they stay on treatment longer. So that's what these plots show for the three different subtypes, the HER2 positives and the triple negatives and hormone receptor positive patients. So that's really kind of ties in the concept of monitoring molecular progression with ESR mutation and switching early based on an ESR mutation. So this same concept now could probably be extended to monitoring just by ctDNA, regardless whether there is an actionable mutation or not, and switching treatment.
What about the other paper in HER2?
Yeah, so this is an example of a de-escalation concept. So that's in the HER2 positive space. And it's kind of the same idea that I described in the Signal ER study, that you delay treatment until ctDNA turns positive. So this is in the metastatic setting for patients who completed actually had at least 2 years of treatment, I think. And they have an excellent response. So very often these patients have a complete response. And then we have this conundrum, how long to continue HER2 targeted therapies. And many patients are on, in my practice, are on this for years, 5, 6, 7, 8 years. And there's always this issue that is it safe to stop? Because there is inconvenience, if nothing else, inconvenience involved is showing up in the clinic every 3 to 6 weeks. And of course, the continued risk of cardiotoxicity as well. So this trial actually will hold the maintenance HER2 targeted therapy if patients are ctDNA negative, and then would reinstitute it if they turn ctDNA positive sometime during their follow-up. So that's basically a study to test this question, that could you safely hold a maintenance treatment in the metastatic setting in patients with an excellent response.
So one follow-up question about kind of relevant to both of these studies. Do you see any role, or have you yourself considered or used a cell-free DNA assay like Signatera in the metastatic oligometastatic setting? You know, you have a oligomet, it gets removed surgically, sort of, a lot of times you hear the term pseudo-adjuvant therapy.
Yeah.
Do you think it might have a role there, or has it been looked at there?
I think it could have a role. So again, I mean, ctDNA is basically just another form of a tumor marker or liver enzyme elevations, so other sort of blood-based markers of the extent of the disease. I forgot to point this out that the previous paper that we just discussed from Memorial Sloan Kettering showed very elegantly that there is a very tight and positive correlation between tumor volume in the metastatic setting and the extent of ctDNA positivity, the amount of ctDNA, or the number of this mean tumor molecule per ml, which is the readout or the actual metric of positivity in the Signatera assay. So I think the practical use of this is not unlike any other tumor marker, PSA or CA2729 or CA15.3. So it's declining, then you could feel good that the cancer actually is responding. Maybe you could spread out imaging. And if it's rising, then you take symptoms much more seriously and you do imaging studies. And at least on some initial results, maybe early intervention at the molecular progression stage may actually improve quality of life or push away clinical progression.
This concludes our program. Special thanks to Dr. Pusztai, and thank you for listening. This is Dr. Neil Love for 5 Minute Journal Club, Circulating Tumor DNA and the Management of Breast Cancer.